When a patient appeals, they actually get reviewed by a specialty matched physician on the payer side, which is regulated by federal law. And we believe doctors in general got in practice to do the right thing and first do no harm, which is the oath HCPs take. And so when you are a physician reading somebody's story with those types of components in it, of their lifestyle, their life impact, and so forth, the chances of making the right decision to really see how that impacts the patient, we believe is higher, which is why we have that high success rate.
Welcome to ClaimTalk. I'm your host, Danielle Young, and today we have an episode discussing a very important topic around claim denials. And as usual, we have a special guest with us today. First time around the podcast, Zach Veigulis from Claimable. Zach, why don't you give us a little introduction about yourself?
Yeah, I'm co-founder and chief AI officer of a company called Claimable. We're an AI-powered platform that helps patients appeal denied medical claims. So if you think of TurboTax, you don't have to be an accountant to file your taxes anymore. And the same goes for filing a comprehensive appeal. You can come to Claimable, answer some questions around your situation, and leave with a fully executed formed appeal letter.
Awesome.
Yeah, it's an excellent tool. Zach was nice enough to give me a demonstration of it yesterday. It's very easy to use, very user-friendly. I also appreciate the facets of AI that you've used to make the appeals process more successful for the patients that are engaging in it, but we'll, of course, get to all those details here in a moment. Amy, do you want to introduce yourself for us?
Absolutely. Amy Pelligren, Senior Vice President and Chief Legal Officer. I joined ClaimDOC about a decade ago, and I'm responsible for the regulatory and legal compliance of the program.
And I'm Bruce Hansen. I'm president of ClaimDOC. I joined a couple months after Amy, so a little over a decade now. And just as you'd expect, I bring all areas of the company together, from operations, sales, service, and ensure that we're operating down the same path and really achieving the vision that we set forth on what we want to accomplish.
Excellent. So we're talking about claim denials today, and there's many different contexts in which we could discuss the way claims get denied. At ClaimDOC, obviously, we're working more on the front end of a claim. After the claim's incurred, of course, we're working on the front end to try and audit, reprice it appropriately, and make sure that it's a fair and reasonable payment for the plan. Claimable, despite having the same word in their title, claim, approaches it a little bit differently. Zach, do you want to give us a little bit more of an overview about how your product helps serve patients specifically?
Yeah, definitely. So just, I guess, to scope the problem for a second. So there's about 5 billion medical claims a year that come through both government and commercial payers. About 1 in 5 or 20% of those are denied. So that ends up being about 1 billion claims a year. Of those billion claims, there's less than 1% that actually appeal. So that ends up being, really less than 2 million appeals a year that come from patients. A little known fact is that every patient has the right to appeal, codified in federal law and also in 48 out of 50 states. However, most patients don't know that. And if they did know that, they wouldn't know how to do it. So effectively what we've done is take the guesswork out of it, right? So if you think about like what the anatomy of a successful appeal might look like, it would be, heavy on insurance policy, pretty heavy on medical evidence, also any protective, laws that might help a patient. Those 3 domains are quite arduous. You really couldn't be an expert in any one of those areas, let alone all of them. So that's kind of what we feel is the reason why most patients don't appeal. So what we do is that when a patient receives a prior authorization denial, they can be referred to Claimable from their HCP, from their Pharma Hub program for patient assistance, or they can find us just in our direct consumer channel, just getclaimable.com. They come to the platform, they answer some questions about their case, and then they leave with a fully formed letter.
I think what's cool about Claimable and how I got really interested in it is denials are a necessary part of insurance. Everybody's focused on cost containment. So you hear everything about, healthcare prices are skyrocketing. It's exactly why ClaimDOC is in business. And then on the other side of people's mouths, they talk about, oh, these denials are terrible. This is really hurting the members. Well, it's necessary. And what I think intrigued me so much about what you guys do is it's a tool to help with that. It's just like policing the laws. Not everybody breaks the law, but some people do. And so you do need police for the people that do. That's why claims are adjudicated. That's why denials exist. But in your circumstance, you're giving people help where, no, they followed the right procedures. They really did need that drug. They needed the procedure, and you're giving them an outlet to do that. And I think we see that through our program, just through our member advocacy, where members of plans that we service will reach out to our member advocates. They're getting help on their EOB. They don't understand it, or they got a claim denied, and instantly it's assumed there's something relative to our program that's causing it. And through that process, our member advocates help them identify, well, no, your claim was denied for these reasons. After that, it's kind of up to that member to find an outlet or a resource to help them with that. And those don't really exist. They're really not prevalent in our industry as the help for those members to get. And that's, I think initially when I saw you guys at the Prometheus Awards, and we both won awards in that same year, and both have claim in our name, just kind of following you guys over the last 3 years and see what you're doing it's been really impressive, and it's really admirable what you're doing in this space.
Yeah, those stats are pretty stunning. I actually haven't heard those before, and I immediately started thinking about, the accessibility to that opportunity to appeal and the information that you need to be successful. Every plan is required to have plan language that is layperson friendly. It's also usually 150 pages long. You don't know where your employer's posted it. You don't know how to interpret the policies. So you get an EOB if you're opening your mail and reading it that might have a code that has 5 words in it related to the denial. And you're supposed to know what to do. Yes, there's language on there that says how many days you have, but it is really an overwhelming situation for the patient to be in and to figure out how to navigate unless their providers, helping them through that.
I know we're talking with more of a self-funded, kind of group here, which makes up about 60% of commercial covered lives, right? One of the things that we feel that a lot of employers don't really have visibility into how their plans are being administered as well, which I know is something that you guys bring the transparency back to that and really kind of cost containment and your goals, which, I think are very complementary to what we have going on. So what we do is when a patient actually comes to the platform, we take their insurance information, we detect whether that's fully insured, union, state government, self-funded, or what have you. And then we apply, if it's self-funded, it's ERISA. If it's fully insured, it could be state law, ACA, and so forth. But the other thing that we do is we highly suggest that on those self-funded plans that patients actually copy their employer on those appeals, right? Because as you guys know, fiduciary duty lands with the employer. And so at Claimable, we have about an 85% success rate for medical necessity denials and established conditions. And so we find that employers really want to help their employees when they're made aware of the situation. But most people don't know that, right? They see, United Healthcare, Anthem, whoever on the Elevance on their card, and they think that is ultimately who they're talking to, when in reality, it's their employer.
Yeah, absolutely. That visibility is, I think, a complex component of this dynamic of insurance. First of all, as you point out, the majority of members on those plans, they look at it as insurance. And if they have UHC or Anthem, Blue Cross on there, they view that as their insurance. They don't recognize that for our employees, ClaimDOC is the insurance. We're the ones paying for those claims. They don't understand that going to somebody internally gives them the opportunity to elevate that issue. The complexity gets even greater because you mentioned the term fiduciary. The plan sponsor also has that fiduciary responsibility to follow the plan document, I think, which adds another layer of complexity that gets into the legal side I don't necessarily understand the most. But then the second layer above that is most plan sponsors have reinsurance. And those reinsurance rates are based on that plan document and the expectation that that plan document is going to be abided by, which then brings into the word interpretation of the plan document that you mentioned. The member can't necessarily do it well. And then you may have the reinsurer interpret one way, the plan administrator interpret it one way, and then the plan sponsor interpret it another way. So I'm curious Amy's take on the plan sponsor's ability to make exceptions, create exceptions, as you mentioned, when members elevate that, because I know discrimination is a key concern, and following the plan document as well.
You mentioned earlier that the guardrails are a necessary evil, and they are, and plan sponsors rely on those to make sure that they are also prudently managing assets, right? It's part of what you're talking about as far as there are plan limitations, there's language, there's standards, and part of that is also to make sure that you're treating patients fairly and consistently. But at the end of the day, the employers really want their employees to have access to care. So I think that's really your point about accessibility and making sure the employers are aware. Then there's the human element and the emotion, and then there's the interpretation. So there are times where an employer has to say, you know, our plan doesn't allow this. And that's probably a really difficult conversation. I mean, we do have those conversations even during our own processes in creating access of, you know, we'd love to get you access to this care, but you still need to get over that pre-certification hurdle. And a lot of times when you're dealing directly with the plan sponsor, it's an HR professional, it's a CEO. They don't necessarily have the benefits or clinical knowledge to do those tasks of interpreting the plan document. So then they rely on their vendors to be the experts. And making an exception, then you have to be careful that you're going to make that same exception in any other similar situation.
Because you're setting a precedent for the plan at that point when you make those exceptions. I want to circle back to something you just mentioned, which is the human element. So Zach was telling me a story yesterday. Do you mind sharing with our audience the story of going to the clinic and speaking to patients one-on-one as you were in the process of developing the Claimable product?
Yeah, absolutely. And just to touch on Amy's point too, which I think segues into that nicely, is inappropriate care, right? And so like supporting that, and you know, we agree, right? Like there's going to be care that's egregious. People are going to be prescribed things off label that are investigational, experimental, and so forth. The way our experience is designed is to only accept patients that have met at least basis consensus clinical guidelines, which kind of segues into this next patient story. So we were doing kind of user acceptance testing with our product about 2 years ago. Before we launched it. And we were partnering with a rheumatology clinic down in St. Louis. And they had basically identified about 60 patients that had faced denials in that month or so prior, leading up to this clinic that we were doing in person. And so what we ended up doing was taking our team, our tech team, our product team, our engineering, everybody, right? And we went to this clinic in St. Louis, and then we saw patients in their exam rooms for 4 days. With those 60 patients, there wasn't a dry eye in any one of those rooms. I mean, it was very, like, these people were, in dire straits of sorts. And so there was one patient in particular, and this really has informed our product, and we still grounded in these principles today. We were talking about the kind of the physical, nature of her condition, which is rheumatoid arthritis, right? And it can be very debilitating. And so she was denied for Humira. And first, nobody's getting high on Humira, right?
It's my favorite phrase from history. No one's getting high on Humira.
No one's getting high on Humira. And so, like, these things, I mean, nobody wants to be on these biologics that have a lot of side effects and so forth. But when you get to a point in your condition where that's the only, hope that you have, like, she needed it. And she'd been on it for a while, and that was the only semblance of life. But we were talking to her, and she's, like, very emotional. I'm estranged from my family. I was like, well, it must be a physical disability that's led to her being estranged from her family. That's really interesting. I started talking to her, and it's like, well, no, I can't grip a spatula anymore. And because I can't grip a spatula, I can't make Sunday dinner. And because I can't make Sunday dinner, my kids don't come over. And because my kids don't come over, my grandkids don't come over. And now I'm completely isolated. I'm depressed. And it was really eye-opening. We've designed in our product in a way to be really empathetic. We're not just submitting these appeals that is, member number 1234 with, J code XYZ that has been denied. We really try to humanize the patient and make both the insured, their employer potentially, regulators and so forth, see these patients as humans and really kind of understand the scope of the impact of their health and not having access to care.
And you feel strongly that the human component of the appeals that you're submitting really does increase the likelihood of winning that appeal?
Absolutely. HCPs are a subcontractor, basically, of the insurance company. Pushing back on that payer to make a favorable decision can lead to some consequences, I'll say, that are not favorable. So there's a story recently, Elizabeth Potter, about a year ago. She is a surgeon down in Texas. She received a call during a surgery from United Healthcare. Patient was literally on the table. I believe it was a mastectomy she was performing, and they denied the claim while the patient was on the table. And so that went viral on TikTok, got a lot of views and so forth. And they ended up dropping her from network, right? So that's a huge impact on somebody who's lives in an area whose patient population is primarily on United Healthcare. And so the financial fallout from that has been pretty devastating to her. And she's been on various media outlets and so forth talking about that. That's not unique, right? HCPs kind of have that, I'll say, hesitancy in general to push back due to those potential consequences. Now, when they do push back, we have stats that show about less than 40% of providers appeal claims. I mean, they're very busy, they're overworked, their burnout's really high in HCPs and so forth. But when they are pushing back in a peer-to-peer where they're talking to a peer, potentially a peer at the insurance company or through, an appeal letter, it's very transactional, right? It's this patient has this diagnosis with this treatment. Here's how I followed your criteria, the end. How we do it is we really, we still capture those elements, right? So the structured elements you'll say of tried and failed, tried step therapy, failed step therapy. We've made sure you've met all of those guidelines. But then pulling out that patient story and humanizing that patient, when a patient appeals, they actually get reviewed by a specialty matched physician on the payer side, which is, regulated by federal law. And we believe doctors in general got in practice to do the right thing and first do no harm, which is the oath HCPs take. And so when you are a physician reading somebody's story with those types of, components in it of their lifestyle, their life impact and so forth, the chances of making the right decision to really see how that impacts the patient, we believe is higher, which is why we have that high success rate.
That makes a lot of sense. And I think for both of our businesses, we're fortunate to be so close to the action at the member level. So with our program and the member advocacy, and then the really lean layers of management we have here, Amy and I get and hear a lot of those stories about how our member advocates speak with people and the situations they end up in. It makes it very human to us, not just as operators of a business, but understanding that human side of the medical benefits world. And I think that's probably a huge benefit to you as well.
One of the things that we've observed quite a bit is that sometimes during those procedures, there may be a piece of it that is determined experimental. And so then the whole procedure then
renders
becomes
the whole claim
it causes a problem. So we do see that sometimes. Or the mastectomy, those can be challenging because, of course, there's a lot of legal rights to protect women. But then there are a lot of pieces of those procedures that may or may not be medically necessary depending on the circumstances. But, talk about something so personal that we have seen other women who have a number of needs, and then a doctor wants to do one piece with that might make her recovery better. And so pre-cert's denying that piece, but not the entire procedure. And we're trying to get her access to care, right? She's enduring treatment, undergoing these really serious surgeries. And it's really hard to balance, the emotional side of that and her making sure that she gets what her doctors recommended, who she trusts, but then balancing this, maybe one piece of the procedure that's experimental.
Like I've established, I don't have an issue with denials. I don't have an issue with the problem that people have with denials. I think my thing is, how do we find the right solution to those? Like denials have to exist, but what are the outlets members have? So in that situation, how does that member know what their avenues are? The thing that drives me crazy, and this is just a constant flow within insurance, even on our own self-insured plan, is that fax you get from the TPA about if you went to the chiropractor, just that immediate assumption that you must have been in a car wreck and your medical, your medical benefits doesn't have to step in and cover it. And to me, it just feels like such a process that was created completely one-sided without ever, like what you guys are doing, flipping the lens over to, as a human, utilizing their insurance, there's protections here. What are my abilities to then work against those protections? And it feels so unexplored within our space by people that understand all the components, because it is complex and layered, but it just feels really unexplored. And we still have TPAs faxing confirmations of tell us about why you went to the chiropractor. And I guess that would fall into maybe the referral side of the medical benefits.
Potentially.
I don't know where that falls in.
It almost feels as if insurance has developed a belief of, let's say no, and then you tell us yes. You tell us why. And I mean, you mentioned those stats earlier, which again, I described as stunning. They really are. But you also use the word transactional. You've got medical care, which couldn't be more personal. And then you've got the collision with insurance, which can't be more transactional.
Right.
So, uniting those two things really is a challenge.
And it's always guilty until proving yourself innocent, almost, with the health insurance.
Absolutely. I was also going to mention, a statistic that I discovered in conversations with Zach and his team, 1 out of 5 claims get denied here and now in the modern day, and that's all claims, right? All claims across the spectrum. It can be commercial payer, self-insured payer, somebody who's on an ACA plan, someone on Medicare, Medicaid. Yep. 1 out of 5 claims get denied, and less than 0.5% of them, I think you told me yesterday, actually go through the appeals process. So to me, that says that there's an enormous swath of the American populace that is in need of a claimable, that is not able to seek the help because they don't know where to go. So your jumping into the landscape is going to be really helpful for consumers. As far as denials, where do you see the most common errant denials in your space? Meaning denials that should not, obviously 80 to 85% of your clients get their appeals approved. Where do we see some of the margin of error in that?
Yeah, it's a great question. So, we work both on the medical benefit side and then also on the pharmacy benefit side. We're primarily right now in therapeutics, expanding quickly into diagnostics and other areas as well. There's a lot of frequency of denials that happen at a really high rate with the same kind of templated denial, same reason that happened from one of the large PBMs that were that are well known to not to name names, but there's a couple of them, but there's one that sticks out in particular, and there was an FEP formulary change that happened this last year on a medication that is pretty high volume, and it treats a number of conditions both on the pulmonology side as well as on the dermatologic side, and they pulled that medication off formulary. So everybody that is on FEP, which is about 1% of commercial covered lives, is on some type of federal employee plan. And all of those patients, tens of thousands, got moved on to something else. Now, formulary changes happen every year. It's expected based on, rebate landscape changing and so forth. But what's really interesting about this particular case was for some of these indications, they didn't actually have any other FDA approved alternatives. And so they had kind of created their formulary based on what doesn't appear to be grounded in any clinical science, and move patients that are dealing with eosinophilic esophagitis, other types of kind of rare conditions that only have one FDA approved indication or therapy. And those patients have been non-medically switched to something else or completely taken off therapy. And the fallout from that, the consequences of that from a health perspective can be pretty profound. So that was a pharmacy benefit manager that is denying a very high rate of claims with seemingly the same templated language, no matter what. And that's on initial claim. And then on appeal, we're seeing, I mentioned that, there's federal regulation that show that these have to be specialty matched physicians inside of the insurance company or the PBM to review the case. We like to say that it's the most sure way that a human actually reviews your care is to appeal. But in this case, how fast these things were firing back and how closely similar they look to each other, exactly the same, there's no way that was happening. Right. So we try to, combat that the best that we can, but there are still some, bad actors in this space, I'll say.
It's the same on the medical side as well. When there's denials and there is a medical professional that gets involved in the denial, they're certainly paid on volume. Turnover and volume is a piece to how they're getting compensated as part of their role within that organization. We're really close to the claims here in that we do the processing for our clients. Most of those claims see and touch our system. And I think the vast majority of denials are more issues between the physician or provider and the administrator, where those get cleaned up, I don't know, through resubmittals or reworks due to coding issues. That you had Cynthia on a prior episode, and she was just discussing the vast number of codes and the complexities and how challenging it is right now for providers to operate in this system of submitting a clean claim. That's a challenge. There's back and forth. So when we look at the denial statistics, I think a massive chunk of that is just the administrative side between the administrator and the physician. And then you start moving into the prior auth issues, the coverage issues, the medical necessity, where those start to fall on, it was denied. There's nothing the administrator or the physician can do about that. Now it lands on that member, and what are the members' outlets to that? So that's where insurance to me is getting more and more complicated.
Yeah.
The administrators know where the provider side is abusing the system in those segments, and kind of to your point, that same code or that same issue kept popping up pretty regularly, and I think that's what we're seeing on the medical benefit side as well. They know scans, MRIs. They're aware that those get prescribed or they get pushed to specialists, and that's costing plans money. It's costing the risk taker money in that as well.
Totally. Yeah, I wish I'd actually known about Claimable sooner than I did, because I went through this process with my husband a couple of months ago. He had a J code that was getting denied that he had previously been taking. It was getting denied by Anthem. And they make the process virtually impossible, and it's more than just in one way. So first of all, we're talking about an insurance literacy gap. Yeah. My husband's a very intelligent man, but I had to get in there and run some interference to make sure that we were going through the process. Number two, they put such a constrictive time frame on the provider to provide an actual response to the appeal. I believe it's like 48 to 72 hours. So if the provider's not on top of that, there's another snag in the chain. And then beyond that, they wanted to do a peer-to-peer review, but they gave a 12-hour window for the doctor to wait for the phone call to come back into the HCP. So at the end of the day, it took me getting involved with the office billing manager every day for over a week to get this prescription approved for a medication he was already taking. I understand they have a yearly prior authorization process, but I think what you're doing is so important because it's also providing an outlet for those insurance, perhaps less literate folks out there who could really use a hand, getting that medication approved and getting it in their hands.
First of all, sorry to hear that, and sounds like it ended okay.
It did.
Okay,
we got through it. Yep.
Okay. So one thing that they don't tell you, which I think this is a really good point, is you receive the denial letter, right, or the EOB, and it gives you some type of instructions on how to appeal, right? And it says your provider or you, or the language is very loose. Well, you can actually appeal independent of your provider. They make it appear as if your physician, ordering provider need to, be the one to drive that. That's not true at all, actually. We actually have stats that show even appending a letter of medical necessity to a denial or an appeal that's completed through Claimable does not increase your chance of success.
I think that's really interesting, and I want to make sure we repeat it so the audience hears that. Including a letter of medical necessity from a physician does not increase the success rate of the appeal.
Yep.
Fascinating.
Yeah, we had it with one of our own daughters, and this was through the dental plan here at ClaimDOC. I don't know if you got pulled into this. I try not to pull you in, but she had a crown put in, and they used a material where it got denied. And so the dentist sent a letter back to them explaining this is following the exact guidelines for why this material is being used. And if this is the way your exception is put together, then you're basically removing this service from your membership. From the covered services. And then it got denied again. And so luckily for us, we have outlets here. We know the outlets. So we worked with Levi, and Levi kept working with the administrator until they finally recognized that this shouldn't have been denied. And it goes back to interpretation of the plan document. There was several bullets laid out, and it was clear in all those bullets, there's a level of interpretation that's going on between both sides. And so having an advocate, in our situation, this was Levi helped us out, continue to push this. Without that, it would have just we would have written a check and paid the dentist and moved on, which is probably what most people do when they don't understand what their opportunities are.
Definitely. I mean, and 40% of Americans can't afford a $400 unplanned expense, right? So like for us, sitting at this table, we would be able to overcome that. Most patients just simply abandon care at that point, right? And that's the sad part about this is, we've heard some you guys have some, very impactful stories on your side, and we hear the same on this side as well. And if you look on the oncology space, which is something that we're in now as well, a 1 month delay in care is a 10% less chance of survival at 5 years, which is incredibly profound for patients. And these are, with the kind of emergence of immunologics and immunotherapy and some new medications that are out there now, things like melanoma, colorectal cancer, small cell lung cancer, those things are very treatable now, whereas prior to they were death sentences effectively. And so patients are living long. I mean, they're curative treatments. Now, I understand there's an ethical debate depending on the staging of that and some of the science that's came out. But we've found some patients that are the best case scenario for this treatment that have, plenty of medical evidence to back. They're going to live long, prosperous lives with care denials. We've also seen the same thing on the workup even to get to that point, right? With PET scans, 40% of PET scans are denied. Those are cheap diagnostic tests that are used to stage cancer before you can even start treating. It doesn't make sense on where some of these are applied in a lot of situations.
But you start to think about that. For us as ClaimDOC, that cheap PET scan is really affordable to us as a plan sponsor, and we would write that in all day. We want all our members to get that. But it comes down to who's taking the risk in that scenario. So if you're doing a fully insured program, so whether it's Cigna, Aetna, United, Blue Cross, it's a huge subset of PET scans. So they look at that, that cost is much larger on the abuse side where they protect from it. Where in the self-funded world, we're able to better understand what that cost is to the plan sponsor. I probably sound like a huge denial apologist in this. I think it's such an important area. I think both things can be right. I think you need denials to properly control costs, but at the same time, there has to be outlets, exactly like what you were providing. What I don't have a lot of tolerance for are the people that talk about denials and how bad healthcare is and how healthcare is way too expensive, and I can't stand denials, and I also want to put in these really complex plan designs that are going to be difficult for members to manage, and yet insurance literacy is a problem for members.
Right.
So they want everything. Everything is a problem, and then they're going to exacerbate that problem with their super complex plan designs. That's where I start to really get frustrated with the process. It's okay for both of those to exist, but talk about solutions. Don't then make things more complicated for the human to actually digest their insurance.
Especially for self-funded plans, you have to be judicious about where you're spending your plan dollars. That's why we exist. We understand that. And obviously there's other conversations to be had around, do we overtest? Are we maybe doing too many certain scans or what have you, and subsequently treating things that aren't necessarily something we need to be treating? Like, guardrails are important for sure, but to Zach's point, no one's getting high on Humira, right? Yeah. There's certain areas, certain gates like a PET scan that we maybe shouldn't be keeping as tightly as we are.
Absolutely.
Thinking, again, down to the patient level, down to the human level.
Yeah, I think that pre-authorization stage is really an intriguing one, and you are in the weeds on it all the time. You mentioned that most patients can't afford an unexpected $400 bill. So that pre-authorization stage, you could also argue, is protective, right? I think insurance often is a little too paternal in their approach. But we have one partner that does not pre-certify chemo. And we've seen a lot of patients go through a course of treatment and then end up with a E&I denial and have $1 million bill that they're responsible for because they didn't go through that pre-authorization process to vet that there would be coverage. So I think that if it works and it's fast and we're not having any of those delays, because that delay is real and the person's scared and they want to get their treatment as fast as they can, because there are going to be times that maybe it truly is experimental and there may be other options for that patient for helping pay for the treatment, but it may not be through their insurance coverage. So that's, again, where there are denials that need to exist, right? I mean, it is a necessary evil, but making sure that we balance that with care that they need, and is this the best course of treatment, and is it covered?
That's exactly the complexity of this whole problem. There are really well-intended people that say get rid of pre-auth. Our brokers are really passionate. Most of them are utilizing reference-based pricing because they're really passionate about helping plan sponsors contain costs. At the same time, they recognize by doing reference-based pricing, they're controlling the price that's being paid, so they want to be as member-friendly as possible. And so they've developed these concepts of get rid of prior auth. But then there's little gaps in there would be you get rid of prior auth, but what happens later on down the road when a claim gets denied because it's viewed as experimental, non-covered service? So there's then a chain of events that creates other complexities. It's, again, not always simple answers to these big problems. I think the answer is always provide service to the member, provide outlets to the member, do the things like what you provide to members, and make that available to people to then work through those processes.
You know, we can speculate all day about, and I don't disagree with anything you said there as far as like what the actual mechanism is to kind of fix this on the front end, right? So when I was I was at the VA for 15 years prior to this. Last 7 of that or so, I was building models that were used in clinical practice. And those machine learning models needed to be vetted. They had to be scientifically peer-reviewed, published. Then after all of that, we would go into, committee and so forth to kind of figure out how we were going to introduce those into the clinical workflow in some way. Right now, like, these claims are being adjudicated on the front end without any transparency at all. Again, we only help patients that have met consensus clinical guidelines. So whether that be NCCN guidelines on the cancer side, or the American College of Rheumatology, or the National Headache Foundation, or, for migraine, it all kind of varies. We always look at what the guidelines say that are peer-reviewed and published and scientifically evident, and then we base, our threshold of helping patients on that. I'd really like to see from the payers, like, a little bit of transparency in how these claims are being adjudicated, because I believe that there's been a lot of emergence of RCM, AI software to submit the claim faster, to make it more complete, and all of those different.
It's necessary for the providers with the complexity.
Well, absolutely, but like the denial rate's going in the wrong direction, right? We're going
Right.
about 20% year over year in the last 5 or 6 years. And so now, why is that happening, right? Why, if somebody's, either been on in the case of your husband, been on the medication for, a number of years and stable potentially, or they've, met all the step therapy requirements for initial authorization, or they have, a cancer case where things have presented in a traditional sense and the treatment's not, new or even emerging, why were those denied, right? And so having the mechanism to push back is great, and that fallback. But, Amy, your point is like how quickly those things, how that happens. And they're supposed to have 72 hours to respond to urgent and emergent denials or appeals. We find that 72 hours is at least 10 days. This is a true story. We helped the patient get on therapy for immunology, and she waited about 30 days. Before that was possible. And so, imagine the stress and just the emotional toll that takes on. We were talking to her about every day, right? And this was a case that we had leaned in on and didn't just leave that up to our automated side of the product. We do a lot of philanthropic work as well. And so, hearing these patient stories is just pretty miserable. And this was like a very cut and dry case. It was something that just defied logic on why that was. So I think if there was more transparency on that initial, here's my models, I'm going to publish the weights of these models, I'm going to show you exactly what it's looking at, what variables we're considering, work with us, right? Healthcare systems, providers, and so forth. Now we've opened the book so you can see what we're looking at, and we're going to make this easy for everybody. That would go a long way, I believe. And if that puts us out of a job, we're okay with that.
Great.
Yeah. And if administrators, instead of relying on networks, use reference-based pricing, they wouldn't have to squeeze the members on denials. I think
One
that's
less layer.
I mean,
You know?
maybe a little bit selfish, but I think that's the answer.
A little shameless
Yeah,
self-promotion in there.
self-promotion is always good.
Nothing wrong with it. Well, Zach, thank you so much for being here today. We are going to pivot into part 2 of this episode. We're going to bring Ben on stage. We're going to learn a lot more about Claimable, specifically get into some AI, some other topics around what you're doing. Thank you so much for your innovation and your disruption in the space. We're really grateful for your work, and we also enjoy sharing Des Moines, Iowa as our home. So it's good to know we've got a good neighbor in town.
Thank you guys for inviting us. This is wonderful.
Yep. Thanks, Zach.
And thank you to Amy and Bruce. If you have not already, make sure that you like or subscribe wherever you listen to your podcasts. We're on YouTube, Spotify, Apple. Make sure you like and subscribe and stick around for part 2 where we learn more about our friends over at Claimable.